I welcome the announcement last week that Pharmac has begun consulting on a proposal to fund a potential cure for people with chronic hepatitis C infection, regardless of the type or genotype. Subject to the outcome of the consultation process, this proposal is a positive development that would increase access for people with hepatitis C. I'm told it's estimated that there are approximately 21,000 people, both diagnosed and undiagnosed, who would benefit from this proposal, who may not be able to benefit from the currently funded treatments. It's also important to help ensure that New Zealand can achieve the World Health Organisation's goal of eliminating viral hepatitis as a major public health threat by 2030. Despite many encouraging advances, I know we still don't have all the answers. There are still gaps to address some of the barriers. A lot more work has to be done to improve access and awareness, to find those already diagnosed but not yet treated, to further promote primary care and prescribing, and to diagnose those who are as yet undiagnosed. The government has identified its priority as building a strong, effective and equitable public health service to provide the care that New Zealanders expect and, I believe, deserve. Our health and disability system has many strengths, and as a nation we are living longer and healthier lives. We do, however, recognise there is more work to be done within our current health system to improve equity. Effective primary care is central to the delivery of care closer to home for New Zealanders. Although some people with hepatitis C will still need to be seen in a hospital setting, today most can and should be treated in the community. Recent developments for people with hepatitis C are groundbreaking in this respect. One of the primary healthcare initiatives from Budget 2018 is to be able to improve access to primary care by extending lower fees, the same as very low cost access practice fees under $20, to holders of a community services card. And that initiative, which kicks in December, will enable over 500,000 more New Zealanders to access those fees of under $20. And for many of them, it'll be an average of $20 to $30 cheaper per visit, and for some $50 cheaper per visit. And those of you who are familiar with the area, and I imagine many of you in this room are, will know that actually it's not just that it's $20 to $30 cheaper, it's that people can actually afford to go and get the care that they need. We want to phase in over time other priorities, including the cost of visiting a GP to other groups. These improvements to GP access should have a positive impact on those seeking testing and treatment for hepatitis C. The WHO tells us that viral hepatitis B and C are major health challenges affecting 325 million people globally. They are root causes of liver cancer, leading to 1.34 million deaths every year. The WHO estimates that at least 60% of liver cancer cases are due to late testing and treatment of viral hepatitis B and C. Low coverage of testing and treatment is the most important gap to be addressed in order to achieve the global elimination goal by 2030. Hepatitis C is the leading cause of liver transplants for adults in New Zealand. These are important issues for our country, and it's time to coordinate our resources and our efforts to tackle this virus. Although we currently have a pan-genotypic treatment funded for people with hepatitis C with advanced liver disease, for many of the remaining people, access is determined by a person's genotype. That is why, as I previously mentioned, I welcome the announcement that Pharmac has begun consulting on a proposal that would mean all people with chronic hepatitis C can access a new generation funded treatment regardless of genotype. And I do encourage you all to have your say in the consultation over the next 2 weeks as that process goes on. In addition to advances in treatment, there have been a significant change in where the prescribing of hepatitis C treatment takes place. A third of prescribing now happens in primary care as more people access the new funded treatments from their GP without needing specialist intervention. This compares to all prescribing being undertaken by secondary care prescribers prior to October 2016. Over time, it's expected that we will see fewer people develop cirrhosis and liver cancer and decreasing numbers of hepatitis C-related liver transplants. Despite these gains, the rate of treatment uptake has been dropping. A lot of work is underway across the sector to help address these issues. The Lab Look Back project led by Pharmac is a tangible example of trying to find those lost to follow-up. It's estimated that up to 1% of the New Zealand population is chronically infected with hepatitis C virus, and that less than 50% of infected patients have been diagnosed. In order to better identify those that have tested positive to the hepatitis C virus but have not been treated, Pharmac has funded clinical work to identify patients and their referrer to offer treatment to the 10,000 now known to be in this situation. It's not important, of course, how someone became hepatitis C positive, just that they need to be tested. The People Like You campaign will contribute to the wider program of work in hepatitis C that many people and organisations are committed to, and I hope and expect you will all get behind it. It's important that we also address the ongoing or future spread of hepatitis C. The New Zealand Needle Exchange Program is working on a communications campaign with a specific focus on people who inject drugs. Needle exchange clinics around the country are reducing stigma, using peer relationships and offering alternative settings for testing and treatment. This is specifically for people who, because of this existing relationship of trust, are more likely to access services through this avenue versus mainstream alternatives. Trying to work in a more integrated way has been a key rationale for a significant program of change that's been underway in hepatitis services across New Zealand since 2015. Many of you in this room have been a part of these changes led by DHB regions. Work is focused on looking at ways of providing more integrated, regionally led hepatitis C services across primary and secondary care. The National Clinical Pathway has been tailored to meet the needs of regional populations. DHBs have also been working to increase patient access by making stronger connections with wider public services and other agencies such as the Needle Exchange Program, prisons and community alcohol and drug services. One example of this is Hauora Tairāwhiti, where I visited yesterday. Hauora Tairāwhiti is the first DHB to make a commitment to eradicating hepatitis C from their local population. The focus has been on enabling equitable access and removing barriers, and I'm pleased to see the DHB, CE, PHOs and community providers, pharmacies, laboratory staff, mental health and addictions, communications and health share staff all working together in co-design. They've co-designed a community campaign to support the eradication of hepatitis C. So in closing, I want to thank you again for your welcome and for your dedication and commitment to this groundbreaking hepatitis C work. You are the people making this happen. I look forward to hearing the outcome of your discussions and finding out more about what you think is important for us to focus on in the coming years. Nō reira, tēnā koutou, tēnā tātou katoa. Kia ora.